Okay, good morning. I want to welcome everybody and thank you for joining us for this segment. This is Lori Galperin. I'm Mark Schwartz, and we welcome you. And give you a little bit of background on this webinar, which is that we direct a partial hospitalization program in Monterey, California. And we, in this evolution, have been working in small tracks with about 25 individuals. And in these tracks, we have one track for eating disorder, one track for mental health, and one track for chemical dependency. And then sometimes we combine the three tracks. And so we're able to look at some of the origins of bipolar or chemical addiction or sex addiction or eating disorder. And what we're looking at are the similarities and the differences. And the common frame which we use in our treatment model is looking at these disorders as disorders of intimacy and attachment. So what we're attempting to do is move the individuals towards earned secure attachment. And our philosophy is that the person presents a symptom such as alcohol abuse, but underneath the symptom is the problem. And what is the problem? The client typically doesn't know. So what we're going to do is look at what's underneath it in some way. So I'm going to go to our first slide, and this is some of Peter Fonagy's data. And as far as I'm concerned, these data change everything, which is that what you see here is that the disorganized attachment seems to be very high in most of the major psychopathology and addictions. And so what separates people with psychopathology from people who don't is the core structure of disorganized attachment. So when you have a program that treats mental health, eating disorder, and chemical dependency, one thing that people have in common is disorganized attachment. So we have struggled over the last 30 to 40 years in trying to understand this. I was lucky enough to be at Johns Hopkins at the time when Bowlby came in. So I got a chance to spend time with Bowlby and Mary Ainsworth. And so have been there from the beginning to, I read Bowlby's book on separation, and it kind of changed everything for me. And it's always been the frame that I've looked at things. And as the field has advanced, it's just been, truly exciting. If you want to be able to get a good glance at this, Dan Brown and David Elliott's book called Attachment, Disturbances in Adulthood. Let me just pull that up. Attachment Disturbances in Adulthood, which we'll give you a reference for. This is an encyclopedia of everything in the area of attachment. And, and my idea is that it's, it's a gift. And also they have a videotape series that they have put out that is just breathtaking. And I really strongly recommend it. And we can give a reference of how to be able to look at that also. So that's the background. And we're going to talk a lot, and we'll try to answer some of your questions along the way, but we have a lot of material, as you can see, and our focus is going to be getting through the material rather than spending a lot of time on questions. At the end, we'll take more of the questions and be able to go through it in some way. And I want to thank you all for coming, and for our old friends. Just it's nice to feel connected again in some way. So the way Lori and I agreed to do this is that I would sort of start something out, and then she would add to it and sort of flesh it out a little bit. So I want to just say a little bit about John Money, my teacher, said to me, when you give a talk, try to identify 5 things you want the audience to know and just say them from the beginning so that people know what it is you're trying to say. So let me just say it very succinctly. I believe that understanding relapse, that the person is relapsing on the symptom, and there's always a function for that symptom and a reason why the person is relapsing. And it comes in layers. So you may deal with one layer of the problem. If the person is relapsing, it means that there's a layer underneath it. Francine Shapiro, who does EMDR, calls these channels. And there's a channel of trauma, which then sort of bleeds into the lower level of trauma, which bleeds into the lower level of trauma. So if a person is relapsing, it means that you've begun to plug into one of these lower channels. Now, what are these channels? I believe that they're around the concept of disorganized attachment. And as I study different people around the country who are attempting to move to what Mary Main calls earned secure attachment and how we're able to do it, I think there are many techniques now out there, and we try to use them all, and then we have our own on top of that. And that's what I'm going to be talking about today, which is how to be able to move us towards earned secure attachment. And fundamentally, and this is sort of the preview of coming events, to me, it has something to do with looking at it from a developmental stance. Dan Brown, in one of his earlier books, talks about the development of self. And he says, early in life, the child gets self-awareness. They begin to see themselves as a separate person, unique. And then as they get older, there's self-cohesion, which is that who they are in one situation is similar to who they are in a different situation. When the ball goes under the table, the ball still exists, self-cohesion. And the third stage is self-agency, where you begin to feel some sense of competence that you can operate in the world and explore your environment. And it's this combination of self-awareness, self-cohesion, and self-agency that creates self-esteem. Now, the lowest common denominator of disorganized attachment is that all four of those dimensions are injured in some way. And so what we're trying to be able to do with adults is help them see themselves in a Kohut kind of way, in Winnicott kind of way, mirroring who they are, and build more of the self system, and to help build self-cohesion. We had a client yesterday who was talking about her movement out of binge eating disorder. And what I asked her how she got to the point of having sobriety for the past 8 months. And she said, well, she said, first of all, I felt like I had lost myself, that while I was binging, I felt numb and totally out of control, and my affect, my emotion was totally out of control. And I desperately wanted to get myself back, is the way she said it. And so as she went into sobriety, she began to regain that sense of self and self-agency that went with it. And then what she said is, I wanted my life back. I wanted to be able to love and be loved. I wanted to be able to have a life. And I knew the only way to do that was to give up my addiction. And so how I see this is that in Bowlby's theory, that there is always this concept of secure base. If your secure base cannot be the people in your life who raise you, then you turn yourself into an object and you turn others into an object. And so what most of our clients are saying to us is that when I have anorexia, I turn to my anorexia as a secure base. And please don't take my secure base away because it feels terrifying to me. And that their anorexia becomes sort of like a lover to them. It takes care of them, it protects them as a secure base. I'm hearing the very same thing from alcoholics. Don't take my alcoholism away because it's my secure base. And so the idea then is that the reason why a person relapses is because they do not have the development of a new secure base, and that they require the ability to have a sense of self, which includes affect regulation, and some concept of knowing who they are and what their life is about in a spiritual base. And so as you see the development of that, then you begin to get full recovery. So we're going to talk about really how to do that today.
This is a description of a child in a strange situation, which Mark will talk about shortly.
With disorganized attachment.
Cecilia displays distress immediately upon finding herself in the unfamiliar laboratory environment, even though her mother, a slightly disheveled, overwhelmed appearing woman, is present. When the stranger enters, Cecilia looks suspicious and ill at ease. She refuses to engage in interactive play. Immediately upon separation, she begins to cry, angrily resisting the stranger's attempts to comfort her. Reunited with her mother, Cecilia cries loudly. When picked up, she does not settle, but continues crying, wriggling uncomfortably on her mother's lap. She does not calm even when the mother has held her for a full minute. As her mother attempts to interest her in the toys, she looks momentarily out into the room, then turns back to cling again to her mother, apparently still uncomfortable. The mother repeats, "Calm down, calm down." "You're okay." Cecilia refuses to get off her lap and engage in play. I'm gonna read it off here because I can't. When the mother leaves again, Cecilia begins crying loudly and crawls toward the door. The stranger enters at once, but Cecilia angrily resists her advances. The mother is sent in almost immediately, and after a lengthy pause, during which she watches as Cecilia continues to cry, she picks up and holds her. However, when she tries to put her down, Cecilia throws herself backward in a tantrum movement. Her mother reaches out to comfort her. Her crying increases and she closes her eyes, throwing herself about. 2 minutes later, Cecilia remains focused on her mother, clinging to her knees, fussing in a petulant, dissatisfied way. She has never engaged with the toys.
Okay, so the reason I wanted to go into detail on this is because in many ways, what you're seeing here at 18 months of age is reenacted, repeated with your client in adulthood, which is that there is a lack of self-cohesion. There is a lack of control. There's a high degree of impulsivity. There's high reactivity. So there's nothing that triggers this more than getting into a relationship with another person. When you get into a relationship with another person, you are going to have drama. You're going to get close, and then you're going to create a crisis, and then you're going to have high reactivity, and then you're going to try to commit suicide, and then you're going to want the other person back. And all that stuff, which up to now we've labeled as a high impulsivity, sometimes bipolar, out of control affect, mood disorder, out of control. Certainly there's a physiologic basis for a lot of this, but at the core of it is disorganized attachment. And so, once we have the client properly stabilized medically, then the question is, how do we begin to repair the disorganized attachment?
I guess the hallmark of disorganized attachment would be, and just stop me if you're going to talk about this more later, with attachment patterns, the child is really having a strategy evolve for attaching, because the child has no way of being safe in the world unless it has a stable, reliable strategy for attaching to the adult mammal, in this case, primate, who can be the source of protection. So with avoidant attachment, with preoccupied attachment, the child has perhaps not an ideal strategy for connecting, in that the avoidant child almost avoids the parent in order to feel a sense of connection, which you can sense the contradiction there. And the preoccupied child is like Cecilia in a portion of this where she isn't able to really derive comfort from the mother. So more is not satisfying. So in a way, the avoidant child looks kind of anorexic emotionally. It's like they're restricting closeness. And the preoccupied child, it's like they're binging, but it's never satisfying. Whereas the securely attached child is able to connect and able to have a response and able to have a strategy that serves them in situations for attachment. The disorganized, on the other hand, looks like a combination of approaches. And so the disorganized child can do two contradictory things simultaneously in an effort to attach. And I think it's those two mutually contradicting ways that create many of the elements that Mark was just listing.
Okay, so let's just sort of now focus on adults. That there's this disorganized internal world where you have a psychophysiological state of a mood disorder, up and down, affect dysregulation, too much, too little. There's then a deficit in what we call now metacognition. What is metacognition? It has a lot to do with boundaries, but what it means is that you see yourself accurately, you see yourself in relationship with others, so you see others accurately, and then the world around you. So there's those three aspects. And imagine if you meet somebody and you can't assess whether that person is going to be your friend or your enemy. Imagine that you meet somebody and you assume that everybody is going to hurt you. And so the lens that you look through with disorganized attachment is through the schema of safety, trust, power, control, and intimacy. Safety, trust, power, control, and intimacy. I don't feel safe anywhere. I can't trust anyone. I feel powerless in being able to do anything about it. Things are outside my control and volition, and being close to people is dangerous. Now, if that is the frame by which you approach the world, then you meet a person and you're able to say, this person seems to like me, but when they find out who I am, they're going to eventually abandon me. And I can't trust this person because I can't trust anybody. One of my clients said the other day, I hate myself and I'm always going to hate myself. And if that's the lens by which you approach yourself in the world, imagine being married, imagine having a successful job. It's only going to be a matter of time till you sabotage that. And so relapse to me is a way of being able to create homeostasis, meaning that if something good happens, I feel like I don't deserve it. I feel like it's going to stop at any minute. So I better take control of it. And the only control I have is to be able to sabotage it in some way. So that's the dynamics of a person who lives in that hell. And so the idea is that if you use 12-step approaches or relapse prevention approaches, yes, you can get sobriety, but it's only going to be temporary sobriety, or it puts a person in a state where they're going to be living a life of hell. So I remember when I heard Marsha Linehan talk, 30 years ago, and what she said is, our goal is to help a person create a life worth living. And I thought to myself, that's it. It's not enough to treat the symptom, that we have to help them create a life worth living. And being sober for many people meant, a life of misery. And what we want to be able to do is hit at the structure underneath the symptom and begin to help the person enlarge the sense of self and the capacity for experiencing joy and happiness. Now, the other aspects of it were the great progress that we've made in treating the dissociative self states. And, that whole field of dissociative disorder has blossomed. And what we've come to realize is that with disorganized attachment, there is always a fragmentation of the self system. And so one part of you feels smart and the other part of you feels stupid. One part of you feels worthy of love. Another part of you is terrified and feeling unworthy of love. And so what Dick Schwartz says is that the polarization of parts inside creates a civil war. And so people are constantly putting energy into having internal battles with self. And so what we decided was that our goal had to be having a person develop a secure attachment with self before they could have a secure attachment with other. Now, that's a fairly new phenomena. What is a secure attachment with self? An earned secure attachment with self. And that's going to be heavily our emphasis, which is there has to be an I before there could be a we. And so getting in relationship with others is sort of premature. That the first goal is having a relationship with self, and that's going to be sort of the first stage of therapy. Okay, so what we're going to find is on the right side, which is that there's going to be the attachment system, in my mind, is sort of like the old Star Trek commercials. But in Star Trek, what you would do is whenever an enemy would come, shields would go up, red alert. And so what happens with disorganized attachment is that the attachment system is a system in the brain, and it's been organized around safety and security. And so whenever a person comes close to you, shields go up and the attachment system goes into the avoidance mode. And so avoidance means red alert. This person's close, this person likes you, red alert. And so when that red alert comes, what you want to be able to do is distance yourself. And the activation of I need to be in control because things are going to get out of control. And so affect comes into that, this deep emotional system. So our first goal is self-awareness. So self-awareness means that you, instead of numbing yourself out, you want to be able to be aware of what you're feeling inside. And so many of basic psychotherapy approaches is to be able to say, how does that make you feel? And being able to notice people's internal states. So Diana Fosha in her affect accelerated psychotherapy is taken from Davenlu, is being able to help the person notice what their internal state is and to be able to be aware of their internal state and use it as a way of being able to guide constructive action. Now that's psychotherapy 101. But what I'm trying to say is that if we could begin to delineate these components of disorganized attachment, we can begin to then understand the problem, which is that, what addiction does is it numbs out that capacity. And the result of that is that in the meta area, in the area of being able to monitor oneself, if you can't know what you're feeling, you can't guide constructive action. And so the early stages of psychotherapy are always around having person begin to be mindful of their internal states and to be able to label them and be aware of them, and then eventually be able to use them in constructive ways. So a person might say, I'm coming into you because I'm angry and my anger is out of control. And so the early stages of psychotherapy 101 is being able to be aware of the emotions that are behind the anger and use those emotions to guide constructive action. And that's the first stage, really, of dealing with insecure attachment.
Well, I think a lot of people with disorganized attachment, because of what they haven't had in terms of mirroring and because of what's been put beyond the pale of being able to access. And here's how I would say it. It's like in order to have self-awareness, you have to initially be mirrored accurately so that you begin to know who you are, what self is, and what's other as you begin to differentiate. Because maybe there's an amorphous sense of everything that then begins to delineate into self and other. then to have a sense of cohesion, a person would have to not be required to shave off aspects of themselves in order to be found lovable and acceptable. And in a shame-based society, it's routine that in order to feel lovable, children, people are required to shave off aspects of who they most innately are in order to win the approval and love of others. And it's more powerful if that's never actually said. It's more impactful if it's just standard practice. And the more subtly it's conveyed, yet consistently, the more a person becomes remote from their own feelings in just the way that Mark's talking about. Then a person develops a sense of agency, but their sense of agency is on behalf of goals that usually are about, again, being loved by others, an external locus of control, or about what they think is necessary because they don't have the innate sense of who they truly are. And so then even at stage 4, when there could be self-esteem, through the sense of accomplishment and mastery, a person's accomplishments, a person's mastery, then don't even feel like their own. And so a person feels estranged even from their greatest accomplishments, and again, unsatisfied. So to begin to get back in touch with feelings is sort of learning the alphabet that then allows for another language, and eventually one hopes fluency in that language. And that language is the language of intimacy with self and other, where nothing is outside the pale, where nothing need be exiled. So before that happens, though, typically a lot of people have exiled whatever feelings they needed to in order to be loved. So it depends. It's variable based on the system in which you grow up. But some systems don't really allow anger, or they allow for the anger of one person, but that person isn't you. Or some systems don't really allow for fear because a system wants you to pretend to be okay when you're radically not okay. And other systems don't allow for sadness because no one knows what to do to intervene with your sadness. So they hurriedly dispatch you to stay busy so that you won't feel your sadness. So this mission of regaining awareness of one's internal states is no small thing. And typically what people have done previously in their lives is some amount of having an on and off switch. So the off switch is often thrown by using some substance, or using something really as a substance, as a thing, as a sense of comfort that doesn't come from relationship. And that substitute thing provides temporary reprieve, but no real resolution of anything that would allow for a sustained sense of self-acceptance and a sustained sense of being able to engage with others.
Okay, so if I was listening to this so far, what I would say is, another workshop where people tell me something I already know. Everyone knows that being able to be aware of your internal states is a basis for good psychotherapy. But I think what we don't talk about is when a person hates themselves, how to change that. Cognitive behavioral therapies, do things like, challenge the, internal self-concept, the self-talk, all that business. And all that stuff is necessary, but rarely sufficient. You can change a person's verbal behavior and even change their self-esteem somewhat. But we all know that the very root of that self-hatred that's so deep down, isn't touched by the cognitive behavioral work. And so the challenge is how to be able to work with that core sense of self. I had a client yesterday who said to me, the first couple weeks that I was in your program, I felt like everything the therapists were saying to me was condescending. And I felt very defensive and reactive to it. And the way I heard that was, early in my career, the kind of client that I couldn't work with successfully was the ones whenever I gave feedback, they heard it as criticism and became defensive and reactive. It's a very difficult form of resistance to deal with. So I asked him, how did that change where he could begin to listen and hear feedback as supportive? Because to me, there had to be a relationship where he and I formed a true connection. And he knew I genuinely cared about him, that my feedback was out of love and out of wanting to heal, and that it wasn't a judgmental kind of feedback. It was a trying to do my job of helping him, become less depressed and not suicidal. And I wondered how that transition occurred for him. What he said to me was interesting. He said, and by the way, most of what I've learned from listening to my clients. They tell you everything you need to know if you ask them. And he said, it was the group that changed that. When I sat in the group for a period of time, it just changed the whole way I saw things and thought about myself. And so when I hear that, what it reminds me of is that the question is, how do you move from a secure base of alcohol or drugs or eating disorder or work or whatever your secure base has been, to forming the capacity to turn to others for self-soothing? And what we do here is we form a therapeutic community. And in that therapeutic community, we have 25 people who are able to care about each other and support each other. And that sometimes is the first time that they've felt a family of choice. And that ability to be able to be vulnerable and open within the group allows them to begin to get some notion of turning to people. Now, 12-step work, I think, is somewhat similar in the sense that what happens is you're going from a primary relationship with alcohol to a primary relationship with the group that you meet with on a daily or weekly basis. And that helps seed the development of a secure base. And so why I'm at this incarnation in terms of treatment is that I want to be able to create a therapeutic community. But it's so hard within the concept of managed care to be able to do that. So in a partial hospitalization program, what we can do is we do 3 individual sessions a week and 6 hours of group or some variation in between. And so what we can do is in a relatively short period of time, usually about a 2-month period, is to begin to have some real characterological change. And that then allows the person to be able to benefit from outpatient therapy much greater. And so that's sort of what we're all about. Okay, so in this next slide, I took this from Larkin and Whiting's work all the way back to 1991, is that a compulsion serves as a clue. And so what I'm looking for is relapse is a form of the client sending me a communication, a message. And that message is, if you have a third ear, you can begin to listen. What is the client trying to tell me? And their relapse in some ways. What is it that I'm not dealing with that I need to be dealing with? And, and the basic model of psychotherapy is the symptom or the affect is always the window into the next piece of work. And so a client would come into me and say, I binged last night. And so what I want to do in my session is I'll recreate the affect of the binge and what it felt like to be in that binge. And when I can reactivate that affect, if you follow the affect back to any time in the past that you had felt similarly, it will lead you to whatever it is that is in the origins of it or the development of it, the etiology, so to speak. So, for example, one of the populations that I deal with a lot are men who have multiple tricks in an evening sexually. So they might go out and have 10 sexual experiences in an evening, or men who masturbate, let's say, to pornography for 3 to 4 hours a night. And if you can activate the affect that's involved in that kind of numbing behavior, and you follow it back, it will lead you to some of the origins of it, leading edge kind of affect. So one of the clients that I dealt with, he says that when I do that, I get these sensations inside my body, and it's sort of a tickling. And so we follow that tickling back, and it takes him right back to an experience where his father was sexually abusing him, and that he felt that same kind of tickling feeling. And when he felt that tickling feeling, it felt safe and terrifying at the same time, exciting and safe at the same time. So, you know, the idea then is that Dan Siegel says neurons that fire together wire together. So what must have happened is that when he was being sexually abused, both the excitement and the terror got fused together and created some, you know, kind of explosion of affect. And that in the reenactment, he's trying to recreate that over and over again. But his mind has completely given the amnesia of the experience. And so what happens is that he reactivates the reenactment of the affect in some ways. So bringing that unconscious into consciousness and helping him be able to see that when he gets those feelings in his body, it's actually a flashback, then begins to help him begin to make changes in control of that behavior. And so the basics of psychotherapy is always taking unconscious material and bring it into consciousness. And the window into that is always the repetitive behavior. So what I'm saying to you is that relapse is a window into the trauma that somehow engraved it in the first place. Okay, so the idea then is that somehow the compulsion is somehow a way of escaping the negative emotion. So if you ask a person, you know, why do you drink? Or why do you involve yourself in a behavior which is so self-destructive? You know, the standard answer is, I do that because I feel bad and it makes me feel good. And so you're escaping those feelings. Now, what does that mean? It means this, that when you were a young kid and you were having the experience of living in your household, it felt like hell. I hate my life. I hate where I'm living. I don't have any control over changing it. I'm powerless. So my only power is to turn the volume knob down and not feel anything. So I think I'll do drugs and alcohol. This is great. I can really be myself when I do drugs and alcohol because I'm not somehow distracted by my misery. And so neurons that fire together wire together. So it becomes a distorted survival solution. So symptoms are always functional. Symptoms serve a purpose, and symptoms came into being as a way of helping a person survive. So when you come in as a therapist and you say, we want to get rid of those symptoms, by very definition, you're going to get resistance because you're taking the person's survival strategy away from them in some ways. And again, I think Dick Schwartz in his internal family systems model incorporated this idea by saying that the addiction is always a form of protection. These are protectors, and they're distorted survival strategies. And so you want to be thankful for those symptoms in a functional way, for the way they helped you survive a childhood that was utterly terrifying and miserable at times. But those symptoms are no longer functional. And so oftentimes there are parts of self that are locked into the past, maintaining these distorted survival strategies, not even aware that these same survival strategies that help you be able to survive back then are now keeping you from having a full life.
I guess the thing that I want to say is you don't have to have been overtly traumatized to have some degree of the same exiling of aspects of self. And perhaps we'll be able to discuss the processes through which that happens. But I think if everyone, loved and accepted themselves and found themselves to be an extraordinary manifestation of the universe, the divine, however one wants to see it, and treated themselves with incredible respect and then treated others similarly, we'd be living in a different world. But it's because aspects of self become exiled. So it's not a question, as Mark talked about earlier, of simply recognizing one's feeling states. It's a process of reowning oneself at the deepest level and being able to become acquainted with what shame and what particular systems intergenerationally have caused us to exile. And cultures also cause us to exile feelings. Culture is just kind of the sum total of our capacities and our deficiencies in terms of the level of evolution we have toward ultimate self-acceptance. So for me, when I look at various behaviors, and I'll quote a client who said it better than I actually could say it. She said, with regard to her self-harm, and I treated her when she was about 16, and her story was actually she had been abused for a period of time, and it was not recognized, and her efforts to get help went unnoticed or unresponded to adequately. But finally, when she was about 10 or so, there was intervention and she got some services, but she was so out of control with all of the stored up feelings that she had never been able to express and that still weren't allowed in many ways by her circumstances. So she said, when I cut on myself, it feels like a day in Disneyland. When I cut on myself, it's like I am feeling too much. I can't control it. It's overwhelming. Then I cut on myself and I feel calm. I feel peaceful. I feel a little bit high. I feel good. But then ultimately I get to a point where I feel so numb, so detached, so distant from anything that I just feel like I'm not even attached to anyone or anything or the earth in any way. And then I cut in order to feel more real, in order to feel something, in order to get back. So the thing that I realized from that is that her self-harm, among other things, but substantially, was the switch that flipped her back and forth between feeling and not feeling. So intrusion, too much feeling, flooding her, self-harm, too little feeling, too detached, too remote, too estranged, cutting, and then she can feel connected again. And I think that many behaviors that a person becomes really dependent on are used for that. So being able to know one's feelings and to not get desperate and to not get panicked and to not be affect phobic as a result is actually crucial. So to begin to have a way to allow feelings and not simply have an on and off switch, but begin to have sort of a rheostat, like a dimmer switch that's 0 to 10, and ways to begin to soothe feelings, ways to begin to address feelings, ways to not have to shove them out entirely or entertain them entirely in a way that seems way out of control is actually crucial.
Okay, so where are we so far? What we started out was to say something about the importance of affect work. Now you're saying, so it sounds to me like these people are talking from object relations and self-psychology. And this is a very Kohut, Winnicott kind of model. And what we're trying to do is seed the development of the real self, as Masterson would say. And that would be accurate. But now what we want to begin to do is delineate how you do that in the basic psychotherapy model. Okay, so there are 3 aspects of it, which we've talked about in our previous webinars. which is the development of the attachment system, the self system, and affect regulation system. And then the accumulation of that around the area of sexuality. And sexuality is always an intimacy, form of intimacy, and it combines these three components. And so I want to say something about all three of these, but I want to remind you that this is a developmental model. And so of all the things that have influenced my thinking, it's been Cuccetti and the idea of developmental psychopathology. And what the attachment literature demonstrates is that if you say, what's the cause of anorexia? What's the cause of sex addiction? The answer to that is it's always a developmental phenomena, and that each thing in your life affects the next thing. So sequential developmental events. And so there are trajectories for the development of each of these disorders. When I was working with anorexia and bulimia every day, what I recognized that there are about 10 trajectories for anorexia and bulimia. And if the treatment had a lot to do with the developmental trajectory, not the manifestation. So if you say, how do you treat anorexia? It's the wrong question. The right question is, what are the developmental trajectories for anorexia, and how is treatment different for each of them? Now, the same thing is true for chemical dependency. There are many, many types of chemical dependency. You know, there's the type where the first time you drink, it sort of grabs you, the alpha kind of model. There are other kinds which are binge drinking and so on. So the right question is, what's the developmental trajectory of the events that have sequentially contributed to the manifestation of this client's symptoms? And is there anything we can write about how to treat that trajectory? And so in this slide, what I'm trying to demonstrate is that if we break that down, like for example, why is this person using amphetamine? Why is this person using opiates? Why is this person using benzos? That oftentimes it helps in each of these areas. And so, for example, if they're flooded with affect and they're having flashbacks, they might use alcohol in order to be able to sort of titrate that process. Or if they're numb all the time, they might use an amphetamine just to feel active and alive. Whereas if a person's experiencing rage, it may be that opiates would be the treatment, for them. So most of the people use these substances as a form of self-medication, and they're functional in certain ways. Let's say you're scared of getting close to someone. A benzo might be a way of being able to numb that out. So this obviously is not black and white, but somehow you have to see what that substance is doing for that person and what makes them susceptible to that in some ways. And it can guide you a little bit in understanding the basis of this in some ways. Now, we're talking about attachment trauma. And what I want to say is that attachment trauma is not just the Mary Ainsworth classification systems of avoidant, preoccupied, disorganized, and so on. Because attachment trauma is, as we began to look at the ACEs, the ACE study, which showed that so many people have these critical events that occur in their life that are overwhelming. What we're realizing is that attachment trauma is ubiquitous, and that most of us have had varieties of events in our lives that have been unmanageable. So as we're thinking about this in a developmental stance, it may be the attachment figure was unavailable, someone died. It may be that the attachment figure was a source of danger. The father would beat you. Maybe the individual felt abandoned at times of crisis. When my mother had my brother, suddenly she abandoned me in some way. Sometimes there's the loss of attachment figure. We got divorced and I lost my father, my mother. And sometimes it's divorce. Sometimes it's social injustice, that I went to school and I was beat up because of this. It could be sexual injustice. I was treated poorly because of something about my gender. so on down the line. And so what we have to delineate with attachment trauma are the subtypes and the trajectory of what goes with that in some ways. Now, when you have disorganized attachment, usually it's all of the above. And that's why it's so overwhelming, because what Schroff showed in his early work was that the boys that were picked on in the playground were not the kids that had some sort of disability or looked unusual. But in 100% of the cases, there were kids that had abuse at home or neglect at home. And so if you have abuse and neglect at home, it makes you susceptible to being treated poorly in the playground. And then the teachers don't like you, and then you can't pay attention, and then you don't do well in school, and so on. It becomes a trajectory where each thing contributes to the next thing. And so that what eventually results in suicidal ideation of an adult is not a event, but a whole series of sequential events. But when the client comes in, they oftentimes won't tell you that. They'll just say, oh, this happened to me. And you're working under a single etiology. That was the problem with doing trauma therapy. In trauma therapy, there was too much of a focus on the trauma, i.e. sexual abuse or whatever it is that happened. And when we began to throw attachment trauma into it, what we began to understand was that the event that we're calling PTSD is related to a whole sense of sequential events. So for example, now we're seeing a lot of military trauma, and we have individuals who come in and they've had, maybe they've killed 30 people while they were overseas, which seems so dramatic that you want to deal with their PTSD. And so there was this emphasis on evidence-based treatment for PTSD. And what bothered me about that was that somehow there was this idea that if you treated the PTSD, that the client was then cured and could then, you could end therapy. And what bothered me about that was that yes, we can treat PTSD effectively through a variety of interventions, but the PTSD is only a sign of other events. And so what we're seeing is that the person who went to Afghanistan had been in a home where they had been treated horrifically. Then they had school experiences that were terrifying. And then they were sexually abused before they went. Then they went over and killed 30 people. And now they're coming out of the military and they feel they have no secure base and they're terrified and they don't know how to live in the world. Now, if you go back and treat the PTSD from overseas, that would be necessary, but it's never going to be sufficient. And so developmental trauma is the underlying piece of that. And that's what we've been poor at recognizing and treating in some ways. I remember when we were working with the Vietnam vets, they would say, well, why would you want to treat sexual abuse? Or why would you want to work with their issues with their mother? And the answer is that Bowlby always said that what happens in the early life sets the way the person is going to react to adult stress. So more and more what we're understanding is that a person who has childhood trauma is the one who is likely to experience full-blown PTSD when they're in a traumatic situation in a war. And so it's necessary to treat the early trauma, the developmental trauma, and to treat the PTSD trauma.
Well, I think that said it well. Just to add to it, I think in the culture in which we find ourselves currently, there's a lot of emphasis on who to blame. And I find that problematic because it keeps people from looking at things head on. And who to blame is really not the issue, especially not in therapy. In therapy, the issue is healing. So I think that Mark talks about cases where there's considerable abuse and considerable abuse throughout. But again, I would say that we all have legacy burdens to some degree, and those legacy burdens have to get worked out. So let me tell a little story if I can. And the clients and I talk about this in shame group each week. It's like, what is the impact and how does it happen that there's an intergenerational transmission of shame? And how does that shame then interfere with the unfolding of the self system? And how then do the things that people do with all of the best intentions unfortunately limit their capacity to react to the things that happen in a way that's not addictive and that serves the self rather than ultimately undermining the self? So if we think about just, I'll use the example of my own family. I mean, my grandparents came over to flee oppression of the sort where, you know, people would ride into their villages and kill and maim and rape and destroy, which is a pretty good reason to try to leave somewhere. And it wasn't easy to leave, and it wasn't easy to get out, and it wasn't easy to go across the ocean, and it wasn't easy with no money, and it wasn't easy when you couldn't take your whole family and you had to find something to do and you didn't speak the language, etc., which is a story repeated often here, is that people often came here to either escape oppression or people were brought here as part of oppression. And so in any event, there wasn't the time and the conditions that would allow healing. So my grandparents didn't have the benefit of any time, and they didn't have the benefit of any contraception. So, you know, every time you had sex, you might get pregnant. And of course, if you're Catholic, I guess that can still be a thing. But the point is, there were a lot of mouths to feed, and there was a lot to do on a daily basis in a very rugged way to feed those mouths. So it was a hard life. And then next generation, my parents. And then you have parents that went through things like the Depression, where, you know, my father had to be sent away because literally his family couldn't figure out how to feed him and so he had to figure out a way to get somewhere else under horrible conditions with no money and really, you know, a can of sardines. And then later in life, he was in World War II, Utah Beach on D-Day. You know, that is not the kind of situation that lends itself to a lot of sorting through of things. And, you know, nobody talked about PTSD, particularly back then. People just lived with what they did and felt, I guess, a sense of pride that they had done what was necessary. So the bottom line is that then generations try their damnedest to provide a better life for their offspring. And then there's no real way along the way that things get fully dealt with, even with people's best efforts at some degree of therapy, at some degree of self-awareness. Not yet, not in our culture yet. So there are bound to be things that get transmitted. There are bound to be things that get exiled due to the necessities. And then it's like later, those things are just associated with negatives and no one ever thinks about it. It's like the old joke about the ham, which I'll tell later. But in any event, there's then tradition that starts, and people just think that the things they've always exiled have to stay exiled. So if your family doesn't talk about death, then nobody talks about death and grief. If your family just had to keep going in order not to perish, then that's what they do. And that's not wrong. That is survival. But at a point in culture where now 3 generations in, things come to the surface because there's space for them to come to the surface. And they don't just come to the surface for that person, but other people are steeped in not being able to look. And so sometimes when you're willing to look at things that other people haven't looked at, you feel like the odd man out and you feel disloyal in a way. And so you say things like, well, everyone did the best they could. So what I would say about that is that even when everybody does the best they could, there are things that are still going to be unresolved and unreconciled within any system. And whatever your grandparents didn't have the opportunity to resolve in terms of, for example, all of the trauma all of the potential racism, all of the abuse to which they were exposed. And then to the extent that your parents hadn't the circumstances either to take on those same vestiges, the same residuals from all of that, that's the extent to which you will inherit it. And in inheriting it, it will not be because anyone failed. It will be because each generation can only do so much healing and then has to pass the baton to the next generation. I would say the reason that's important is it really authorizes you to look at everything you need to look at to heal yourself. And that's no disloyalty. And I've seen many, many occasions where actually parents and families are very freed up by a person actually beginning to do their work. And the trend, you know, sometimes people resent having to be the torchbearer in the family that is willing to look at things that other people have patently ignored. But I would say that often it's an act of courage, and often it keeps other people who were forebears from having to go to their grave, never having processed and talked about things that are deeply, deeply held and a source of shame and a source of regret.
Okay, so the concept then is that addictive behavior is a sign of a failed protector. These protectors are protectors that somehow came in to help us survive situations that seemed overwhelming, but are now sort of dinosaurs that are getting in the way. And so it says here, when one part gets the idea that it has to somehow coerce and shame her into dieting, working, being nice, usually a parent monitoring and scorning. These parts are inner censors and tyrants that control us and keep our noses. So the first question that we ask is, what are you afraid would happen if you give up your eating disorder? What are you afraid would happen if you give up your binge drinking? What are you afraid will happen if you give up your suicidal attempts? And it's $1 million question, because if you listen to the answer, it will tell you everything. The most common answer that I hear about this is the client will say, I'm afraid I'll be alone. Now, if you just think about that statement, God, I mean, everything is in that statement. I'm afraid I'll be alone. So you're taking something away that they're paying you to take away to sentence them to a life of aloneness. And so we don't want to do that. We don't want you to be alone. And so the next statement would be, if it was possible to have you stop doing that behavior and you were not alone, but you felt like you had love and connection, would you be willing to give that symptom up? Sometimes you get the answer of yes. Sometimes you get the answer of no. If you get the answer of no, then the question would be, what else would need to have to change for you to be able to give up that symptom? And the client will say, I need to have a way of getting back at my parents for hurting me. Okay. Now, what they're telling you is the function of the symptom and what the symptom serves. So if you work on them not being alone, they're going to continue to relapse. If you work on them not being alone and a way of dealing with their anger and wanting to get back at their parents or punishing themselves, each of those functions are necessary to deal with. And if you deal with them, the symptom does go away. It's just amazing.
Well, let's think of another example that's to illustrate this point as well. So let's say as a child, your sibling, your brother, has something, your younger brother, he has something that causes him to have to go to the hospital a lot, and your parents have to go with him, and they have to work and they have to go with him. So how you adapt to that is you become without needs, and you become capable of handling everything. So you handle everything, you seem to be without needs, you're fine because you can see that your parents are entirely overwhelmed and that your brother, who you're a little bit jealous of the attention he gets, but you can't say that because he keeps going to hospitals. So you can't tell anyone how you feel about that, and you just become, as perfect as you can be. The problem is that the adaptation outlives the situation that gave birth to it. And so it generalizes out and it becomes your way of being a good person, being acceptable. And you might say, well, what the hell's wrong with that? Well, the problem is it's in overdrive. And so you become a person who feels constantly that they have to put their needs secondary to everyone else's. And you become a person who's okay no matter what happens. So you find yourself in situations where things happen and you feel you just have to endure it. And you attract people who put their needs ahead of yours because, well, you always put yours secondary or last on the list. So the problem is that the very thing that really served you and the system originally is actually getting you in situations that that are very unfulfilling and that cause you then to need to escape in whatever way you need to escape, whether it's workaholism and then drinking or whatever escape it is. And so to resolve the original situation and to deal with the part that was your protector and said, we'll have no needs, we'll help out, we'll be ideal. That part has to begin to feel, number one, appreciated, because protective parts, their attitude is kind of like, really? I've had your back this whole time, and now what? You want to give me a gold watch and retire me? And in reality, these protective parts have more skills than just the one they've been using over and over and over again, but they get stuck in the well-worn pathway, and they can't really give it up until the part that they're protecting is not as vulnerable. So a part that has to make you into the perfect, needless child and then adult is protecting a part that maybe feels lacking, that maybe feels not so lovable, that maybe feels bad because it's kind of jealous and needy underneath this covering of seeming just fine. And when this part comes out often, it comes out by like breaking free. Like, so say you fall in love and the part breaks free temporarily because good things can unleash captive parts as well as traumatic things. And the part comes out and suddenly it just has all these needs. And so typically what a person does is exile it until the next time circumstances cause it to come up. But in actually beginning to bring healing to this part, what happens is the protector actually can begin to relax once it realizes, oh, it doesn't have to step in, because these failed protectors are kind of like, parentified children that have to take on a role for which they're absolutely not suited, but they do the best they can. But they really would like it if someone else could take over, but someone who will allow them to feel appreciated for what they've done in the interim.
Okay, so what we tried to do here is categorize that. I said to you that there are functions of these symptoms. And whatever the compulsive self-injury, it could be parasuicidal behavior, it could be drinking, it could be binging. These are all, they have more in common than they have different. And they each serves a function, but if you knew what the functions were and you could then help them be able to meet those without the addictive behavior, the person was be more likely to begin to relinquish that symptom. The inverse of that is that the reframe is that when a person relapses, relapse is always part of recovery and they're not being a bad patient. And B, that relapse is a gift to the therapy because it tells the therapist that there's something that is missing and another layer of what one needs to deal with. So there are usually several functions of a symptom. And so my metaphor has always been sort of like going bowling, which is, you have 10 pins. And if you knock down 8 pins, you might get partial symptoms change, but you have to hit all 10 pins in order to get a strike. And so you have to understand all the functions of the symptom and the different layers. And also it morphs, meaning that the symptom can function early in therapy for one thing and it can change. For example, let's say the symptom is a way of self-punishing. Then later in the therapy, the client forms a relationship with their therapist and they're afraid that if they don't have any symptoms anymore, they're going to lose their therapist. So then the symptom serves a new function, which is, keeping the connection with the therapist. And so beginning to understand this model of the functions of the symptom. So what we did is we just listed here some of the ways that symptoms communicate. So the idea is that symptoms are always speaking to you. Listen to them and see what it is they're trying to be able to tell you. On the right side is sometimes they're saying that I look okay on the outside, but in the inside, I'm utterly miserable. Or that sometimes there's a double bind inside where on one hand, I feel the one way, and one way I feel the opposite way. And so on one hand, I feel preoccupied attachment and I desperately need someone to love me. And the other side, I feel avoidant attachment and I'm terrified to get close to anybody. And the only solution to that is to be able to numb myself out. Well, if you don't resolve the double bind, you're not going to be able to resolve the symptom. So you want to be able to listen to what's behind the symptom. It's a form of communication. All right, so the idea then is we have to begin to see the development of the real self. So a variety of therapy models have tried this. For example, Dan Brown and David Elliott have what they call the 3 pillars. And they've devised what's called the ideal parent paradigm. And in that model, what you're trying to be able to do is seed a model of what secure attachment would be. Because if you haven't lived secure attachment, if you don't know what a healthy family is, even in your mind, you can't even conceive of what it would be like. It'd be very hard to create that internally or externally. And so what they do is they use a variety of internal techniques to begin to facilitate that.
So in this model, what they talk about are essentially what are the basic fundamentals that are necessary for secure attachment. And I really like the list because it really, I think, delineates both the foundational piece that is needed and also what it is that the caregiver does or is that allows it. And I think the reason that's useful is not just to know what was and wasn't there, but to also know how to accommodate for it in current life at some level. So just I'll name them quickly if I can find them. So the first one is a felt sense of safety. And a felt sense of safety is created by the caregiver being very protective, not overly protective, not overprotective, not underprotective, but like a mother bear, like a lioness, protective, so that there is safety. And the second one is a felt sense of comfort. And comfort is provided, that may not be the second one, but comfort is provided by timely soothing. Now, if you think about it this way, if you think intergenerationally about a parent who never had soothing, and you think about their ability to actually access something in themselves to provide soothing, I mean, it's more surprising when a parent is able to do it than when they're not able to do it. In that slide that we read earlier of Cecilia, when her mother says, "You're okay, you're okay," that, for example, does not really provide a sense of soothing for the child. And I would suspect that, you know, more often than not, people do what they were, what they experienced, and unthinkingly, and think, well, it's good enough for me. However, that's really not soothing. So a felt sense of safety, a felt sense of comfort, to be seen and known. Everyone wants to be seen and known. I often say until they don't, because shame causes them to feel too scared to even want to be seen and known. And so then the person has a contradictory sense of desperately wanting to be seen and known and being absolutely terrified to be seen and known, which, as Mark said earlier, is why group psychotherapy, though people initially fear it, winds up being one of the most powerful tools for neutralizing shame. Because in a group, people realize that nothing they can really say about themselves is foreign to the other people in that group. And they are able to feel a sense of being understood, being seen, and being known. So the way that happens is by a caregiver having a sense of attunement. And attunement is not just empathy. Attunement is being able to join and flow in the rhythm of the other. Fourth is feeling valued. And I can't think of how Dan says it quite ideally, but I remember very well the caregiver quality that allows for it, and it's the ability to delight in the child. And I think so many times when people are under whatever duress they're under, the pressures of, you know, of life as it used to be, and also the pressures now of modern life, the space to feel a sense of delight in your offspring rather than the child feeling burdensome is maybe not as pervasive as one hopes. And when it is, that's some cause for appreciation and congratulations. And then finally, the sense of, and I can't think what this comes to, but it's the sense of that comes from encouraging the person to be able to explore in order to discover their sort of best self, or really their unique self. And so the quality of allowing, as opposed to over controlling and creating the destiny for that child, is to allow there to be room for the person to find themselves. So when any of those are lacking, the ideal parent therapeutic paradigm, one element of it is to create a set of internalized ideal parents, not in lieu of the ones you had, but totally separate from that. And so people initially feel like, what? But it actually winds up being extremely and compellingly powerful, because to create an ideal parent team internally allows a person to begin to respond in a different way to oneself, and to not have the whole burden be upon the self for that. So a person will utilize the internalized ideal parents to respond in just the ways that are most needed for that person. So there's not a standard set of internalized ideal parents. It really is based on the qualities that are most essential and the needs that are most perhaps undermet within the person. And it creates over time a much greater sense of stability and comfort. You might say that the same thing could potentially be created by in internal family systems by a person being able to access the self and to have other parts step back so that protectors don't run in to deal with every crisis, but instead there's a clearing so that the self, capital S of the person, can emerge. But I find these two approaches collectively to both be extremely powerful in different ways that serve the same end.
Now, let me apply what Lori just said, that all approaches to trauma work have been stage one is self-care, to attend to sleeping, eating, exercising, and other forms of self-care. But what they haven't fully realized is that the person has no frame of reference of what the hell that means to have self-care, because it's not just sort of the behavioral exercise of exercising. It has something to do with an internal state. When we're talking about forming a secure attachment with self, it's deep structure of recognizing self-compassion. Those words don't mean much. So Dan he wrote a book earlier in his career on hypnoprojective techniques. And what he did was he divided hypnoprojective technique in the ideal parent paradigm to begin at a very limbic level, to have the person have some frame of reference of what self-care and self-compassion would be. And so in these psychotherapy exercises that you do with the client, you begin to implant the depth of understanding of what self-care really means. It's a very powerful technique. We use it as sort of a foundation because, if I even want to show a film of what it would look like to have healthy parenting, honestly, I don't know if I could find a film. I'd have to look really close. And most of that stuff that we do, I don't know, I always find it's a way of making the false self more false. And what I mean by that is, I'm going to pretend like I'm taking care of myself, but it's not real. Because if you hate yourself at a depth level and you're eating, sleeping, and exercising, then you're basically making the false self more false. And so at some depth level, you have to change the core structure of hating oneself at the foundation. So this is that beautiful Winnicott quote: "The principle governing human life could be formulated in the following words: only the true self can feel real." And so the question is, what is false self and what is real self? And false self is what the client will tell you. I feel like I'm an imposter. I feel like I'm whatever other people want me to be. And so what I came to see is that above the superordinate concept for all addiction is codependency. Because in codependency, it's a form of a primary intimacy disorder. And what happens with codependency is that I feel unlovable. And the only way I can really allow myself to have any connection is by trying to avoid disappointing people, and by being able to be attuned to what it is they need me to be and to be that for that person. And that's at the very superordinate category of all addictions. And so the real self is being able to be in your body, embodiment, and to be able to listen to what's going on inside, and to be able to re-own these disowned parts of self in the psychodynamic model. And each time you re-own these disowned parts of self, your capacity to feel joy and happiness increases dramatically. And so the cure for depression is always finding out the parts of self that one disowned and bringing them back into the body, enlarging your capacity to experience fully the world around you.
Now, no one wants to do that because those parts hold feelings that a person spent their life typically trying to not feel. So I think then the important thing to let people know is that there has to be a certain amount of self-care, whether you like yourself or not, just in order to be able to do the work in therapy, to go back and be able to revisit and unload these feelings. These feelings can be unloaded, but not through avoidance. That's just suppression. And just feeling the feelings without resolving the cognitive distorted thinking and the attributions that have come to accompany them is very important as well. So part of what is getting unloaded has to do with affect, has to do with cognition, has to do with somatic feelings, but it absolutely can be done, but it can't be done while one is, stressed in every way. Like you can't cure PTSD while the person is still in the traumatic situation. So, because at that point they need their defensive structure. So the person has to begin to treat themselves reasonably first, even before there's the motivation or the care to treat themselves reasonably. I'd like to give an example while this is up of the kind of layer by layer process, just to make it a little more understandable in a treatment context. So once upon a time, I had a client who had been utilizing bulimia for, I suppose, about, I don't know, at least the last 7 years of her life. She was in her 20s, and she had been using it really to function. And so every day before she had to do any kind of schoolwork or anything that took concentration, toward the end of the day, she would binge and purge whatever number of times, feel some relief, and then it's as though she could focus. So part of what she was using it for was to address her anxiety, and to change mood states, and to then change over to something that then allowed her to feel a sense of ability to concentrate and focus. So first we had to solve that issue, like, let's look at the time of day it is most there, and let's think about other ways that you can shift gears, other ways you can deal with the anxiety that comes up, and other ways that you can focus and concentrate. So we did solve that. And then it just was habitual. So every day she had to really think about it. And there was some effort involved in choosing to do the thing that was less familiar. But after about 20 or so days of it, that really, she could see that the new way of doing it accomplished something as profound with less of the negative effect. So then the next issue was she was afraid that by not purging, she would gain weight, and that maybe she needed to increase her overexercising, and maybe she needed to restrict more if she wasn't going to purge. So then we had to refine her meal plan, have her work with a dietitian who could help her look at her belief system about that and create a meal plan, and then test out her belief system. And I remember this very well about her, but the thing that she realized was that actually she could, over time, it took a few weeks, that she could eat whatever she wanted. And by beginning to become aware of hunger and fullness and satiation, the cues of which she had knocked out completely by what she'd done with food for all those years, that it began to let her trust in her own body again. Then to look at why she and her body diverged and where that happened in her life, that she felt her body was something that needed to be controlled, and that allowed to be out of control, it would, balloon in some horrifying way that she would be out of control of. So we looked at some of when it originated and not just the ongoing usage of it. So she realized that actually she didn't need to overexercise. She was very physically active, and she realized she could eat anything. So it was like a whole new world. But then there would be urges to binge and then purge at times when she felt a sense of aloneness. But she had very much learned not to recognize aloneness as a call for action. And so even though she had friends, she didn't tend to utilize them. So she really underutilized her friendships, and people really felt deeply for her. I mean, she's a very wonderful human being, but she didn't really know that about herself. And one reason then, as we looked back into, well, what originally made you think that you had to not have any needs, she talked about being an only child and her parents' lack of awareness of parenting. So they treated her like, a tiny adult from the beginning. And then when she was able to begin to utilize her friendships more, which was very hard for her, that was harder than changing the need to purge for any other reason. So it's like her eating disorder was a comforter. So then over time, we began to have her utilize friendships, which is very, very hard because she didn't want to burden people. So she started to use friendships, and she found that some people were able to have mutuality, and some people were really glad to be able to be there for her in a deeper way. And it was a revelation to her, actually. So then at that point, we went back to look at what are some of the underlying things that shaped you in this direction now that come up intermittently, now that you're not binging and purging each day, now that the urge to do so comes up maybe once every 2 weeks. When does it come up? And looking at when it comes up, then the things that happened earlier on in attachment became the focal point. And in addition to her parents not having much of a sense of parenting and sort of having banished the child inside them and made a bunch of rules to go with it, then her mother would behave in a very childish way and her father would behave in a very parental way. And so literally what she saw, she had done internally. And so she treated parts of herself that seemed frivolous with dismissing them. And so she realized that her friends were actually now treating her better than she was treating herself internally. And so initially she came up with the things she would say to herself instead of the top 10 things that she was saying to herself. The top 10 things she was saying to herself when she felt in need of something or sad about something or just a feeling that hadn't really been permitted growing up, she would say something dismissive. And so she thought about what she would say to her best friend. She thought about how she would be with, a puppy, and came up with something to say along those lines. And then she began to actually just say those things. And Mark said, of course, words themselves don't necessarily change the underlying apparatus. However, it makes a huge difference to begin to talk to someone in a different way, especially the self. And then out of that, she began to do some work unloading things from the past and beginning to integrate more and more parts of self. And in that, she really became able to play again and to have pleasure from many more sources. And therefore, the need to binge and purge receded even farther as a method of release or as a method of mood alteration, because now she had many, many, many other things open to her, including friendships, including play, including food, including all of the pleasures of actually living.
Okay. All right. So I think what Lori said illustrates how you apply this clinically. What I want to do now is I want to dissect it. So we're now going to look at cognitive behavioral tools to be able to facilitate this process. So let's start with self-awareness. The first thing we do is have the client do a timeline. And here we borrow from narrative forms of therapy. In narrative therapy, what we want to do is look at a story of your life around loss, a story in your life around shame, a story in your life around trauma. And Marilyn Cloitra does a beautiful job of laying out the delineation of these narrative scripts and being able to talk about them in group and build them so that there's a combination of cognition and affect. And that is a form of exposure therapy. And Mary Main talks about self-cohesion as part of that. And in self-cohesion, the importance is that you can understand that every effect has a cause and that everything that you do makes perfect sense. 2 and 2 always equals 4. And so if some of your behavior makes no sense to you, to begin to look at it from a developmental stance and make sense and meaning out of the fact that what you do always is rational. And if you can understand what the input is, even if it's primary process input, it always relates to the output. So I could say you've had 3 affairs and you love your wife or husband. There's a good reason why you do that. And in this model, you must understand the etiology of that in order to be able to treat it effectively. It isn't enough to do the phenomenology of it. So self-awareness comes first. Now, part of that is values clarification. You have to know who you are. And so from there, what we've borrowed is acceptance and commitment therapy. Acceptance and commitment therapy has one component, which is knowing what your values are. And there's maybe 30 values that people have. And what we do is have people explore their values, because most people, they don't even know what their core beliefs are, what makes them unique, what their idea of integrity is. And my idea is that one has to have clarity about the rules of how you want to live your life. And anytime that you behave in a way outside those rules, you're going to feel distress. And so I want to do something in what Kohlberg used to call moral development and values development. And I want to help them begin to mature beyond the childlike level, and that they know what their values are and that they behave within the context of that. That then begins to define the uniqueness of self. And what we facilitate is a unique self kind of component. There's only one of you, and you exist in the world as a unique soul. And what is it that's unique and special about you? And to be able to notice that and be aware of it. The third area then is self-agency, which is we give them homework assignments on a weekly basis of things that, whatever they want, they have to begin to take action to be able to create whatever that is they want. There's a great sense of learned helplessness and powerlessness that so many of the clients have. And what we want to be able to show them is that they have control, and the control they have is over themselves. And they may not, the idea of approximating, beginning to get one's needs met. First, you have to know what your needs are. The result of self-awareness, cohesion, and agency is self-esteem. And so each time they have a negative self-statement, they need to challenge that and be aware with, flashing red neon lights that the ways that their self-hatred manifests itself. Fear has 1,000 faces. And so when they're afraid of something and they are avoiding something, typically they're going to have some sort of negative belief about self and others. And I don't know, in the trauma work, the key aspect is making meaning out of suffering. And so that process of doing trauma therapy is that somehow they get to the other side of the tunnel, and that somehow they can make some meaning out of suffering and turn that into a form of self-esteem, i.e. they're a survivor and they're incredibly resilient, and to notice what they do right rather than what they do wrong.
If I could just add a bit to each thing. Under self-awareness, when you're talking about they're doing a timeline, it's not just the negative things, it's everything. And what people tend to leave out is as important as what they include. It's like some people will be like, I was born and then I went to high school. It's like, okay, well, that was very brief. And it tells you something about the what's missing. So I would say, though, that their resilience, their ability to persevere, their mastery of various things, I think a lot of people focus heavily on what they haven't yet been able to do or achieve or master. And there's a wealth of things to notice about where they've already been and how they endured, persevered, escaped, lived through, or made the most of. Two, when Mark talks about cohesion, I think cohesion in a way is about knowing that you can trust yourself in a variety of situations. So knowing that you're not going to, there's something that will be available to you throughout situations, good and bad, and that there are things that define you. I think that when Mark talks about rules, it's kind of like in AA, they say, if you want to feel self-esteem, do esteemable acts. And I think that's certainly true. So sometimes you have to paint by number also, rather than just paint. And so it's like, I think a person can have a set of guidelines of things that they will and won't do, will and won't engage in. I think ultimately, though, what has to happen is that the empathy system has to come back online. It has to come back on toward the self, and then it becomes available towards others. And I believe that at that point, decisions about values can be made based on the even higher plane of accessing one's empathy and thinking about how it feels and how it feels to be the other, rather than just a regimented series of rules for oneself.
Okay. Now, Lori and I have been training the adult attachment interview, and we got trained actually with Dan Brown by some of Mary Main's colleagues. And it was so enlightening, because by then we could begin to understand disorganized attachment with a different frame. One of it is involving, which is, what causes you to have a score of disorganized attachment or unclassified in the adult attachment interview. There are two things that would be really critical. One is the idealization of your family. That loyalty to the family is probably the major resistance in all psychotherapy. So as people begin to look at their past without using rose-colored glasses, it sounds like they're being disloyal to their family system. And so what one wants to do is to be able to be aware of all the things that are positive as well as the things that are negative, and to be able to balance them in some way. So trauma work is not just identifying the bad things, but there's appreciations, there's regrets, and there's resentments. And so one looks in a balanced way at all of those appreciations, regrets, and resentments, and puts them together without rose-colored glasses. And that's breaking down the loyalty of the family. Two is this concept of involving, where they learn that the only way to get love is to take care of others. And that's a very hard block, because
Well, I guess really what you're describing is helping the person to be a person instead of an object. So sometimes a person is the bad object, and sometimes the person is the good object, and kind of being the good object is almost more ensnaring than being the bad object. So if you learned to get love by meeting everybody else's needs, or you learned to derive what looked like love by being perfect, or if you learned that you would only get love if you let other people live vicariously through your achievements, then things have to change, but those things are actually harder to relinquish for something that feels like an uncertain outcome of whether one will still be loved.
as we're talking about these things, I want to begin to shape the treatment program. If we wanted to do work around self, then a lot of that's done in individual psychotherapy and forming a frame of an individual relationship. So we believe there has to be, individual psychotherapy as a very core of the model. Then there needs to be highly targeted group. And so Lori said she runs a shame group. That's a really key component. We also have a boundary group, which is really a key aspect of this. And we have a codependency group, which really focuses on these fundamental areas. And so we're trying to give education and accurate information and then in the group applying it to the individuals in the room in their own biography and how it manifests itself, and then lay out sort of how to begin to change that pattern in some ways. In the individual therapy, a lot of what we're going to do would be at the basis of Gestalt work. And so there's a variety of ways of doing Gestalt work these days. Internal family systems is a very profound way. Parts work, ego state therapy, affect accelerated therapy, all those. But fundamentally, it's beginning to recognize what is a dissociative phenomena. And that oftentimes when a person's in a relapse, they're in a dissociative state. Why do I say that? Because they're doing something that feels numbed, that feels out of their control, and is antithetical. So if you say, I'm coming here because I feel like I'm dying, and what I'm doing is killing me. I'm drinking, a gallon of whiskey a week, and it's slowly killing me, and I don't want to die. By very definition, that's dissociation, because there's a part of them that wants to live, i.e. they're in your office, and there's part of them that wants to die because of their behavior. Or, anorexia. If I want to be able to feel the energy to be able to have my day, but if I don't eat, I don't feel that energy. So there are parts of self that are at war with each other, but they're not going to label that in that way. So begin to use the parts designation helps them understand that actually what they're doing is fairly rational, that there's a part of self in a functional sort of way that is doing something for a good reason, and there's the opposite or polarized part. So the basic goal in dissociative theory is to let the parts become to be delineated and to be able to facilitate internal communication of the parts. Because in Dick Schwartz's model, if you have two members of the family living in the same house, one has to find a way that two of them can be able to live together in that house, i.e. marital therapy. And that forms basically from communication, problem solving, conflict management. And you have to apply those same principles internally for parts that are dissociated to learn how to live in the same body. So dissociative theory is enormously helpful in working with fragmentation. Now, the final piece of this is what we call metacognition. And metacognitive therapy is really beginning to be robust. Bateman wrote a really beautiful book called Metacognitive Therapy for Borderline Personality Disorder. And Peter Fonagy's book is probably, the most useful thing that you can read on metacognitive-based therapy, because he has something called reflective function and a reflective function inventory. We find all this incredibly essential because the basic deficit is knowing one's own mind and knowing other people's minds. Because how can you feel safe in this world if you don't know your mind or someone else's mind? And trauma destroys the person's metacognitive capacities. And so we are delineating those and beginning to work with metacognition. And again, if you want to understand this stuff, because it's fairly esoteric, go to Dan Brown, David Elliott's book, because they do the most incredible job of laying out all the work that has been done in this area, particularly a guy named Liotti's work from Italy, which is really helpful in this. So metacognition is treating one's mental contents as objects on which to reflect. And if you think about your own maturation, think about how whenever you're upset about something, you allow yourself to get clarity. I know for myself, if I'm really upset or stressed out, instead of just reacting, I like to sleep on it. And when I wake up, I get total clarity about what's going on, why it's going on, and what to do about it. But when I'm in the moment and I'm having all that intense emotion, I just become numb. So learning how to be able to tolerate affect in a Marshall Linehan DBT kind of way, and to be able to reflect upon it. So the power of DBT, dialectical behavioral therapy, is in affect tolerance and being able to ponder one. And so it's a beautiful model for metacognition. So DBT is a central component of what we do.
One thing just to throw in with the last thing you said is, I think that urgency is not your friend. And metacognition is having the space and the ability to think about your thinking. So just to make it simpler.
All right, it's 10:50. I feel like, just to be fair to you all, we need to stop and just sort of take some questions. And so I'm going to turn to the question answering and begin to take some of these questions you're asking. Feel free to add some in. First question is, what happens to people who have mental health, eating disorder, and chemical dependency? And it's the right question, because that's the whole basis of our treatment model right now, which is that most of the people we have them all. And sometimes they don't present them, and sometimes they minimize them. But, honestly, they typically have each of them. And so what we'll oftentimes do is multi-track them. And so, we have to get them sober first. And then once they get sober, we'll move them over to a separate track. In a clinic like ours, you can have somebody come in principally for chemical dependency. And then once we get that stabilized, then move them over to the mental health track. And it allows them to be able to have more time for their insurance reimbursement, but also it allows us to be able to work at both levels. And, managed care has been fairly supportive of us. They make sense to them. Get somebody who's come in here, this is their 7th treatment program. And I'll say to them, to the person at the other end, listen, this is not going to be their 8th. If you just let us do the work, we can get them out of this. And we can make a good enough argument, they typically will support us. That in a PHP program, it says no one-to-one therapy, and the trouble with billing. And what I would say is that that's probably why we started our own PHP program, which is that the focus has to be less on money and more on quality of care. And so what we've done is we've set up a program with the focus on the primary care of the patient rather than on profit. And, I don't mean to be too cynical about this, but, the idea is that by clinicians owning the program, we can really put the focus on doing what's necessary to be able to give to the client what they need. And I think 3 individual sessions a week is the essential piece of the program. And without it, I don't think we could be as successful as we've been. There was a question saying about EFT, emotionally focused therapy, and the power of that. And emotionally focused therapy is an attachment-based model, and we probably have under-mentioned it. But I love what's written in that area and what's lectured in that area. I use that particularly in couples therapy, and working with couples. It's really a useful model.
Your question about addressing the racial and cultural trauma that occurs, I think, is crucial. And I like to address it in terms of how it came down through the family system and how it was experienced by the person at different points in time. So, for example, a friend of mine in the South told me a story the other day that she'd never told me before. And it was with her grandparents, and when her grandmother's life was threatened, but she picked up the phone and they thought she was her grandmother, and her life was being threatened because she was registering voters who certain people in that town did not want to be able to vote. So I think that looking at how it exists, not just at a political level, but at a personal level, is very important.
So anyway, we invite any of you who have questions to sort of get in touch with us directly. I think our email is on the original cover of your slides. You can write us and we'd be glad to answer anything. And, when COVID is up and you want to take a vacation, come out and visit us out here. We live in heaven, right on the ocean in Monterey. And
except when the air's smoky, but still.
It's a great place to recover. Okay, thank you all for coming and have a great day.
Thank you.